We're trying to bring a really simple solution to a really complicated problem. Give every American a trusted, independent health and medical partner who's there for everything they need for the rest of their life.
Thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together.
You're having a bad day one day, right? A couple of people got laid off from your team at work. You're feeling the stress, you're nervous, you're feeling badly for them. So you don't go work out that afternoon, and you have an extra glass or two of wine at dinner, right? And that messes with your sleep just a little bit. So you wake up the next morning just a little bit more tired. When we're a little bit more tired, we're more easily agitated. Stress gets to us more. So the stress that started yesterday actually gets a little worse, and you get a little bit more agitated, and you don't feel like working out. And because you're not working out, you're eating a lunch that you don't usually eat, right? And so now you're starting to put your blood sugar in that mode. And by the way, that wine also has more sugar in it, and your sleep wasn't as good. And so now you're letting your glucose levels swing a little bit more. You've had a little less sleep. You're eating more than you're accustomed to, and you didn't get the exercise you need, which also contributes to your sleep, right? Tires out your body and all that, makes all those positive chemicals. So now your sleep gets a little worse again that night. And the next day you get into this cycle, right? And it's not just your sleep cycle and your stress cycle and your diet cycle, but it starts to affect your digestion, right? And the frequency with which you're using the bathroom. And you get it takes only a matter of days to get your whole system out of sync. And it can take weeks, if not months, to get it back. Right? And if you don't realize that's what's happening, and you don't realize how all of those things are connected, then you can't manage those things to get back into sync, right?
It's the idea of inertia can work in both directions, right? So you talked about those kind of cascading effects of the bad habits. All of a sudden, you got to stop that inertia and pivot. Well, the good ones do the same thing, right? You start getting in the positive rhythm. Now, it's easy to, of course I'm going to go to the gym today. It becomes habitual.
Oh, my wife's took up running in a big way when our third kid was born, as her way of getting back into shape.
I thought maybe she was running away from the kids.
Maybe there was some. Well, it was good. I mean, when you're training for a marathon, you're out there running 3 and 4 hours at a time. Somebody else got to be with those kids on Saturday morning. So I think that probably is part of it. But it becomes like a disease, right? I mean, running is. I mean, it's a positive drug addiction, but it's kind of like a drug addiction.
I could believe that.
And you need it. You need those. Those positively flown chemicals. You need feeling better. You need your body to feel tired and worn out. You sleep better. It's a good kind of sleep when your body's tired. And it's, so yeah.
But you don't wake up in the same kind of deficit that you'd wake up from the night that you had a couple extra drinks that didn't sleep.
Well, the devices even tell you, I mean, if you've worked your body really hard, one night of sleep might not be enough recovery, right? I notice after, 2 or 3 days, so I like to play tennis. If I play 2 or 3 days of hard tennis in a row, that's another thing. My heart rate doesn't get, on that third night, it doesn't get as low as it should because I need a day or two off to really recover. And your heart rate and how it lowers at night is an indicator, right? Your heart rate, when it gets to its bottom and starts coming up, that's the key sign that your body is kind of in recovery. And so if your heart rate's still trying to drop lower, when you're waking up in the morning, you're not done recovering.
So that's that percentage recovered in the sleep, tools that they give you that feedback, right?
Yeah. So I mean, the data is really valuable data. I agree with you. I mean, you don't want to obsess over it, but just the education and the self-awareness that you get out of it is really, it's important information.
Well, I think this is a good start to the podcast, man. We already started, but I might as well actually introduce you, David, and introduce Amaze real quick. So why don't you say who you are and give us a brief synopsis of what the episode will be about for the listener then?
Sure. David Silverstein with Amaze Health. Amaze is designed to be your trusted, independent health and medical partner for everything you need for the rest of your life.
Okay.
That sounds like a lot.
Yeah.
But we're a virtual solution, right? So that doesn't mean that we can our mobile app doesn't deliver babies yet, right? Can't repair your torn ACL. can't do an organ
like how you said
transplant.
yet, though,
Right.
so maybe
Yeah,
someday.
we're working on those things. Do you know that there are now X-rays the size of your mobile?
I would believe it. That would make sense as an application.
Super low energy, so they don't require a shielded environment, usable by EMS. So, fire department comes, they think you've broken your leg, they put basically a screen under your leg, a device the size of a mobile phone, take an X-ray, can shoot it off to a doc to review. So the technology is coming really fast.
Yeah.
I think those giant MRI machines, that's going to be a few years. But anyway, the real point is, we believe that everybody needs a trusted and independent medical partner. You used the analogy when we were talking earlier of what we all would like primary care to be, what primary care, that term didn't really exist 100 years ago, but what family medicine was 40, 50, 60 years ago, where there was one doctor who you would go to for your preventative care. You would go to when you were sick. If you needed to be admitted to the hospital, they could admit you. You didn't have to go through the ER, right? They could direct admit you. They would visit you and round with you. If you needed to be under the care of specialists, they would be speaking to those specialists. And you had a trusted medical partner. The system we have today doesn't really allow that. And I think doctors would like to get back to that world. I think patients would like to get back to it. And so at Amaze, that's essentially what we've built using modern 2025 technology to do it.
Cool. Well, let's go back in time before we come back forward and really dive into what the Amaze model is. Obviously, you've had a really successful career in a number of different capacities. There's I think a legislative component that you've helped shape some policy. But I'd like to really quick just hear a little bit of your CV for the folks that are listening and may not be familiar with your work.
Sure. So I've had my hand in healthcare, I'll just start there, for 25 years. Okay. So I, along with a couple of others, founded a company in 1999 that would best be described as a management consulting firm, did a lot of operations consulting, and some of the first big implementations of what was then known as Six Sigma, lean principles, originally comes from lean manufacturing, but really driving the efficiency in hospitals and other kind of organizations. So worked with a lot of hospital systems and insurance carriers. So United's been a customer, Cigna, the third largest hospital in the world, which is a 3,200 bed hospital in Johannesburg, South Africa, places like a war zone.
Wow.
So I had my hand in healthcare through the payer and provider lens for a long time. And then a little over a decade ago, sitting at the kitchen counter one night, my daughter started peppering me with some questions about a medical bill that was sitting on the counter.
Okay.
And I couldn't figure out where her questions were coming from. She suddenly had this intense curiosity about the healthcare system. And after a few minutes, I figured it out. She was feeling guilty about this bill that was sitting on the counter.
Okay.
It was a $12,000 bill. She'd been playing basketball as a 14 or 15-year-old, hit her head on the floor, concussion, off to the ER.
Oh, wow.
And so she's staring at this $12,000 bill. And I'm trying to explain to her not to worry about it. We only had a $1,000 deductible. It hasn't even been processed by the insurance company yet. I'm actually going to just throw it in the trash, until it comes again. And as I'm explaining the healthcare system to my daughter, really, really sharp kid, she'd known since she was 10 years old, she wanted to go to law school. She's looking at me like I've got two heads.
Yeah.
So instead of just paying the bill, I said, why don't we have some fun? And let's ask all of your questions of the hospital.
All right.
Right. And one of her questions was, well, does anybody pay the $12,000? And I said to her, well, actually, some people do, people that don't have insurance. Imagine to a 14 or 15-year-old kid how unfair that sounds.
Yeah, of course.
And so we start writing letters to the hospital asking about their prices. And we got one letter back that really just set me off.
Okay.
It was a letter from a hospital in Colorado that said, I'm sorry, we can't give you our prices. That's proprietary information.
Okay.
Think about that, right?
Yeah.
Our prices are proprietary. We're asking you to pay a bill, but our prices are proprietary.
Yeah. Or you can find out about it in arrears after you've already paid it. We'll tell you what the price is.
Exactly.
Right? Yeah.
So we decided to have some fun, and we wrote back and said, we perfectly understand. Unfortunately, our credit card number is proprietary. And we played around with the hospital, and then eventually I paid the bill.
Okay.
Didn't know what else to do.
What did that $12,000 end up getting? Do you remember what it got
I
down
think
to?
I think it was our $1,000 deductible.
Yeah. No,
and I think the bill was $2,500.
Yeah, exactly.
After adjudication. So then I had to. I was sharing this with I had, not Amaze, my management consulting firm, had an ER physician working for it who we gave the title of chief medical officer to. And I was sharing this with him one day, and he said, Dave, you shouldn't have paid the bill. You should have just kept asking your questions. And I said, yeah, I know. I wish I did, but unfortunately I paid it.
Yeah.
And once you pay the bill, they're not going to answer any questions for me, right?
Yeah.
They're not even answering my letters. So, but I still wanted to stir the pot. I had to wait another 2 years for that same kid to go off to college and find her way to the ER 3 times her freshman year in college.
Oh, geez.
So the first time was another concussion. I thought we were done with that. She's 5'2", going to a D1 basketball school. She wasn't going to play basketball, but somehow she thought it was a good idea to play center on a co-ed flag football team.
Okay.
The second time was for pneumonia because she would run herself down. The third time was because it wasn't pneumonia and they'd misdiagnosed the pneumonia and back to the ER for something else. So now I've got these 3 bills, and we decided we're going to have a lot more fun this time. So we started pushing the buttons of the hospital, and ultimately, the hospital walked away from $20,000 bill. No negative credit report, no lawsuits. We put them in a box where there was just no way they were going to get paid.
Okay.
And we realized we were onto something. Me and I had an in-house attorney who was a litigator by background, so we're having some fun. So we decided to form a nonprofit and help a lot of other people do the same, trying to force hospitals to become more transparent in their pricing.
Interesting.
We actually called it the denial of payment system, the nonprofit called Broken Healthcare, brokenhealthcare.org. And one thing led to another, and that really drew me into public policy. As I'm seeing this problem of price transparency, I was really starting to get a sense of not the consumer rights aspect of it. People ought to have a right to know what they're paying. I get that, but it doesn't really solve problems. I was starting to see things through the lens of economics, and realized we really have to get to a truly transparent healthcare system, or our healthcare system is just going to keep getting worse and worse. So I put my daughter on the assignment one summer, kind of a summer internship, if you will, said, find me a state legislator who's going to carry this legislation for us. So she started making phone calls and scheduling meetings. We finally found a legislator who was really interested in our legislation. We tried to run the legislation in Colorado. It ultimately failed. But some folks working on similar issues at the federal level picked up on it and asked me to come.
And what was this legislation in particular supposed to do?
In particular, it was, everybody talks about price transparency and price lists, hospital charge masters, standard charges. This legislation required insurance companies to publish their negotiated prices.
Okay.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
That's where economics really happens, right? It happens at the marginal price that 2 willing parties agree to, and that's an insurance company and a hospital that have negotiated a price. That's the only thing you can use to indicate what a fair price actually is the price 2 parties willingly agree to, not a price imposed to them, imposed on them by the government or anyone else.
Yeah, we don't want price fixing, right? You just want a voluntary transaction where both parties get value.
So we knew if we were going to start to change the economics of healthcare, we had to get at the negotiated price, which is, today what's known as the transparency and coverage rules, or what a lot of people refer to as the quote unquote machine readable files, because that's the format that the files.
What was the pushback you received at the state level initially? Because I think you told me it was a pretty sound legislation, but.
Well, we called it tripartisan legislation. So we had I started with a Democratic legislator. Democrats said we'd never get Republicans on board. We got Republicans on board. Then we got libertarians on board. So for Democrats, it was mostly about consumer protection. For Republicans, it was mostly about being pro-business and pro-market economics. And for libertarians, it was just free market.
Yeah.
So there was no pushback. We were getting ready to go into a committee vote. The straw poll, we had a unanimous vote going into committee.
Wow.
And just a few days before that committee vote, the big guns came out. So it looks like the lobbying firms, all part-time in Colorado, just didn't have enough power and didn't have enough lobbyists. Lobbyists were flown in from Washington, swarmed the Colorado state capitol. And interestingly, even though it was Democrats that we started with, and Democrats were all on board, the lobbyists targeted Democrats.
Okay.
They essentially paid off Planned Parenthood to take a position against this bill. And the position was that price transparency was really, and that I was a right-wing nut job, and that this was a cloaked anti-women, anti-gay, anti-lesbian, today we'd call it anti-LGBTQ bill.
I can't make the connection in my head.
You can't make, exactly. Because so it went like this. So they waited intentionally till there was only about 36 hours left before the committee vote. So these ideas could be planted in Democrats' head and they wouldn't have time to validate them. So the idea was a 16-year-old young man who's decided he's gay, has gay sex for the first time, and goes running off to his pediatrician for an HIV test. And because the pediatrician has to send an item, there was a line in our legislation with transparent pricing that required everybody to get an itemized bill without having to ask for it.
Okay.
So they picked up on that clause. Because an itemized bill would be sent to the parents, the kid would be outed.
I see.
Right?
Okay.
Think about how crazy. Or a young lady that talks her parents into paying for an abortion but doesn't know that's what they were paying for is going to be outed to her parents.
I see.
And so I actually had some Democrats come to me after they killed the bill and apologize. They were angry that they'd been duped. They realized how ridiculous it was, but
it's too late.
We can't take the chance, right?
Yeah.
I'm like, you're.
So it couldn't be something as simple as remove that line from the legislation.
Wasn't time.
Yeah, there wasn't time.
All the amendments were done.
Why do you think so much power was thrown up against that legislation? I'm sure you've
So
spent
it was,
some time thinking about it.
So it was a U.S. senator that shared this with me. Pharma, the biggest pharmaceutical industry lobby, and the American Hospital Association put up the money.
Okay.
And presumably, the way I understand it happened, I don't have access to all this information, was the money was dropped into Planned Parenthood PACs and organizations around the country. They knew that if this legislation passed in Colorado, it was good legislation. It would ripple across the country.
I was going to say, you were onto something with that much of a headwind.
Right.
Yeah.
And we also tried to run it as a citizen ballot measure. Very similar. We actually got to about 45% of it was killed at the Democratic State Convention in Colorado using the same arguments. And again, legislators who spoke out about it, wrote about it on Facebook, called me the day after they killed it to apologize. But
you got notice of the federal legislation, right? Yeah.
Yeah. So there was a U.S. Senator, Tom Coburn, who unfortunately passed away a couple of years ago of cancer. Really good guy, physician, was in the Senate when the Senate Healthcare Committee was created, I think in the year 2000. And he wrote about what we were trying to do in Colorado in the Wall Street Journal.
Okay.
And interestingly, he wrote about it about 3 weeks after the bill had already been killed. But anyway, that led to some folks at the national level reading about what we were doing in Colorado, saying, hey, it looks like you understand this better than we do. This is what we're trying to accomplish. Will you help us do this at the federal level? So that turned into an executive order that under the first Trump administration that was signed in June of 2019. Those rules took effect only in the middle of 2022, so July of 2022. So they've only really been in effect for 2 full years, 23 and 24.
Okay.
2022 was kind of a throwaway year. And quite honestly, I don't think the Biden administration, and this isn't a political statement, I don't think they understood the full scope of the gift that they had been given because it wasn't their rule, right? And so they did start to implement it in 23 and 24. That information is public now. I mean, you can go look up the negotiated price for all of the insurance carriers for every procedure for every medical provider in the country.
Okay.
The problem with that data is, as Cigna at one point had on its website, they wrote, it took us a 48-core computer to compile this data. We think it's silly. We don't know how it's going to help consumers. 120 gigabyte files. Your typical laptop has 16 gigabyte of RAM on it, so you can't even download the file.
Right.
Right. Your hard drive may only have 200.
So you have to beef up your own computing power just to be able to ingest it.
But it was never about consumers.
Yeah.
Right. It was sold as being about consumerism. It was really about businesses. And so the simple analogy for what those rules do is, when you go fill up your car with gas, this is actually the argument I had to use with the White House economists because they weren't getting it. When you go to fill up your car with gas, do you go driving all over town shopping for prices? Do you whip out your Gas Buddy app? No, you just go to the local gas station and you fill up. You probably can't even remember what you paid the last time you filled up your car. Was it $3.45 a gallon, $3.52, $3.79, depends where you live. So gasoline is competitive down to a penny or two a gallon, right? That's a fraction. So if 3-4 cents was 1% of the price, a penny or two a gallon is 0.25%, 0.5%, and it's a super competitive market. And yet you're not shopping around every time you buy gas. Why do you do it? And interestingly, we all intuitively know what I just said to be true, but I had never found anybody who could just articulate the simple reason you do it. And the reason is because you trust market forces are at work. You trust that the gas station on that corner can look across the street and see what the gas station on this corner is charging.
And somebody's not 5 times as much down the street, right?
Because because one, you would notice, they'd get called out in the local newspapers. Some local PhD student would do their thesis on how they can get away with it. But you might charge 3 cents a gallon more because you've got a newer, cleaner convenience store. Maybe you're on the right side of the road during rush hour.
Makes sense.
And so, but even in a competitive market, so you're talking about 1%, 2%, 3% price differences. In healthcare, you're talking about 50%, 100%, 200% sometimes. It's just, they're uneconomic principles.
Yeah.
So the price transparency rules were really about restoring economic fundamentals to our healthcare system.
Yeah, and I think most people would agree, like, we would like to know ahead of time what something's going to cost, or at least within reason, right? Knowing there might be complications and some variables entering the equation. It's a main premise behind a bundled surgical procedure is that you know.
But I put it in slightly different terms. So I agree with you. We do want to know the price. When you go into a restaurant, you look at the menu and you look at the prices. But you didn't look at the prices very closely before you chose that restaurant. Right? You sort of in your head, you're going to a high-end steakhouse, that's going to cost you $100 a head, or you're going to an Outback Steakhouse, it's going to cost you $25 a head, or you're going to a Wendy's, or you're going to a McDonald's, right? And so you think in very broad strokes. So you want to know if the hospital you're going to or the surgery center you're going to, first thing you want to know is, do they charge fair prices?
Yes.
For most people, that's as much as they need to know. If you're a little bit more price conscious, you want to know if you're going to the Ritz-Carlton or the Courtyard Marriott, both good, safe hotel systems, but you want to know, which are you going to?
Yeah.
And actually getting down to the actual price that you're going to pay for your procedure. Well, if you're thinking, I need this procedure, you may never actually get to that, right? So maybe you'd like to know it. Maybe you don't need to know it. But what you do need to know is, kind of what category is this in terms of quality, service, accessibility, location. All of that applies to healthcare, just like it applies to restaurants and hotels. You need to know, is it safe? And you need to know, am I getting charged a fair price? And then if it's coming out of your pocket, you're going to start looking at, okay, am I willing to drive another 20 minutes to save $50 on this $1,000 procedure? And that becomes a decision that you're making. But just normal economic rules kind of say that these are one-time purchases, higher dollar ticket items. When you're getting your car repaired, you want to know that mechanic is or dealership is charging you a fair price.
Yes.
You're probably not going to pull your car out of the shop and start driving around town looking for 3 bids to save $50 or even $100 on a repair. So there's some threshold at which that starts to become meaningful.
Sure.
But if you start with the premise that the prices are all transparent and you can assume they've been set by the marketplace, then you don't have to do so much shopping around.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
Yeah, I mean, I think that's totally fair. And then so outside of the legislation, which I think is fantastic, when did Amaze enter your life, or when did this idea come in, and why?
So I told you we'd formed that nonprofit. We were helping other people with disputing their medical bills. Nothing but a money sink, but it was fun and very educational.
Yeah.
It was fun, and it was very educational. It taught me a lot about the system. That's where those bills were coming from. Taught us a lot about the law. We had to really understand that to help people dispute their bills without their credit being attached, without them getting sued. And we learned a lot about how little Americans understand about our healthcare system.
Yeah.
And you know what? I think the system often paints people as fools, idiots. But think about it. The American healthcare system, it's nearly 20% of our GDP. And today it would rank as the 3rd largest economy on the planet. To say you understand the healthcare system and how everything works would be like saying you understood everything about Germany's economy, right? Not one sector of the economy, but everything about Germany's. There's no way. So the first incarnation of Amaze was really going to be about patient education and navigation, 2 things that employers were really looking for. And we started piloting some classes. So my management consulting firm did a lot of corporate education. So we had some guinea pig customers that had been customers for more than a decade, 2 decades, who trusted us and said, would you send some people to this class? We'd like to test out this class. We tried 1, 2, 4, and 8-hour classes.
Okay.
And then we went in and actually piloted that with a couple of companies. And at one of the companies, the CEO said to me, Dave, this is great. My people feel like they've learned so much. But you've always taught us that people forget 70% of what they learn within about 3 days, if there's not some reinforcement. How are people going to remember these things? How are you going to guide them? So we started moving from education into that navigation space. And then just as we were getting ready to roll Amaze out, so we started building the technology in 2018, 2019, we're piloting these classes. We're building our first team of patient navigators, patient advocates, we called them. And we started looking at where we were going to refer people for medical services.
Yeah.
And we're seeing the teledocs and the MD lives out there. And we're just not liking anything that we saw. So I got with a friend who was a physician and said, hey, I'd like to start a medical practice. Are you in? And we talked over the course of several months. And he said, yeah, I'd like to be part of this.
Okay.
So we formed a medical practice and decided we were going to stand up our own virtual medical service. We rolled Amaze out in February of 2020. You'd think
perfect timing, huh?
You'd think it would be perfect timing, right? You'd think COVID would be really good for a virtual healthcare business, but not if you have a total of 0 customers the day COVID lockdown started. So we did exactly what we didn't want to do, and we pivoted into the retail transactional medicine business. We had no customers. We built this technology team. We had medical providers. From very early on, our philosophy was everybody was a dedicated W-2 employee. So now we're paying medical providers, and there's nobody calling them. Mm-hmm. So, Teladoc is facing 27-hour wait times when COVID first, when all the medical practices closed. Perfectly understandable. You can't blame them for that. They had no idea their demand would blow up 100-fold, right, in a matter of hours. when all the lockdowns started. But so we started putting up, Google ads, and if Teledoc's got a long wait time, call us. And we started taking calls. And we provided a very different system. When somebody paid us for a call, that included 30 days of follow-up.
Interesting.
With them. So if we wrote a prescription for somebody today, we were checking in on them tomorrow. And if they were still having symptoms in a week, and remember the early days of COVID, this was a very common thing. People didn't know where to go get tested, right? They were afraid, right? Can I go to the supermarket? Which one of us should go? I'm 70, my husband's 65, but he's a smoker, and which one of us should go to the supermarket, right? Mm-hmm. People were calling with questions like that. Who else would they call?
Yeah.
Right? And so we started providing a whole different level of care and service and follow-up and continuity. Next thing you know, people are starting to run low on their prescriptions for their blood pressure meds. Their doctor's office is closed. The number one call that we would get was actually for oral infections and abscess. Because all the dentists thought, remember, it's surreal now to remember, but they all closed. No dentist wanted to say, oh, meet me in my office, and you're going to hang your mouth open when we're all terrified of COVID, because in the early weeks, right, nobody knew.
Yeah,
I mean, you probably remember going to the supermarket, you're wearing gloves, right? There was one designated member of the family that would go, right?
I was the supermarket
right?
guy.
You were yeah, me too, right? Had my gloves, had my, the disinfectant wipes. You'd get home, your wife's wiping off the boxes, right? I mean, it all seems really silly now, but when you don't know,
you
don't know. So we were that resource for people. Then we had a few employers starting to stumble upon us, and we became their virtual COVID contact tracer. When somebody would get test positive for COVID, we'd be responsible for directing everybody else to where they could go for testing. We were doing the check-ins, the questionnaires for essential workers going to work. So that sort of helped us start to get back to the B2B market, the employer market. But we didn't really get back to the employer market till the end of 2021.
Okay.
And that's when Amaze, as we know it today.
Would you say, would that period of time kind of be a blessing in disguise for the business, though, as you look in hindsight, or no?
Yeah, no. I mean, when somehow you figure out how to make, so it was very painful.
Yeah.
But one of the things that benefited us most when we were so small was the relaxed cross-state telemedicine licensing, right?
Okay.
So we were able to quickly cover all 50 states. So by the time we got back to the employer market, that had been huge. Now we'd gone through the process. We'd gotten, all of our physicians were licensed in all 50 states. Many of our physician assistants and nurse practitioners were licensed in 10 to 20 states each. And we probably couldn't have done that and been taking on customers, exercising our systems, without the relaxed COVID emergency rules. And to be in the employer space, if you want to take on employers more than 50 or 100 employees, they're going to have employees in other states. Yeah. Right. So you can't be a local business. One of the things that I think has been a challenge for a lot of the direct primary care firms is their geographic constraints. Yep. Right. Yep. And their footprint. And so we started with an all virtual first, and we went out to all 50 states pretty quickly. We have patients in all 50 states. We probably have clients in, I guess, 40 states. But even the client, in Arizona is going to have 3 people in a sales office in Honolulu.
Well, and as you said, and you gave us a timeline, obviously virtual primary care to some degree existed prior to the standing up of Amaze. So was there a particular element of that old model that was missing, or that you thought you could add value to, which gave you the impetus to start the business?
Yeah. So I think, there was very little virtual primary care coming out of telemedicine companies. And virtual care, wasn't really broadly accepted yet, but it was happening. All the early virtual medicine firms were built around brick and mortar models, just moved online.
Okay.
Right. So virtual waiting rooms, appointments. We took a very different approach. We call the principle zero friction. You open up your Amaze mobile app, you tap a button, you're connected to a doctor in 15 seconds. Mm-hmm. No triage process, no intake forms, no questions to answer. We already know who you are. We just got a digital token. We see you on the screen. We put our medical team out front, so there's not a triage nurse in front of you or between you and the medical provider, because triage is something that's bothered me since my very early days as a management consultant, walking into a very suburban emergency room, asking, what the hell is the triage process for? Triage is for war and mass casualties. We were doing some work in a hospital, pretty big hospital in South Carolina many years ago, and it's about 3:00 in the afternoon, and I walk in, and I had a team of consultants there. I walk in, and nurses are roaming around in the back area, and the waiting room is empty. And I said, "What you doing?" And one of them said, "Just waiting for our first patient. We tend to get busy in half an hour from now." I had to think about it for a while. I realized, it's when school gets out.
Yeah.
Sports injuries start.
Yeah.
Kids are sick. Parents don't know where else to take them, especially in poorer communities. So by 4:30, the waiting room is full, and the nurses still aren't that busy. And I said, "What's going on? It looks like you're busy now." She said, "Oh yeah, just people got to get through triage first." And I said, "Have you ever done triage?" And one of the nurses said, "Oh yeah, we all do triage. We all start there. You got to pay your dues." I said, "So you remember how to do it?" And they kind of laughed and said, "Sure." I said, "Anything that stops you from just going out in the waiting room and grabbing a patient?" One of them said, "Just somebody telling me I can." So I grabbed one of the docs and we talked for a couple of minutes. He's like, "Go get a patient.
Yeah.
Let's try it." What do we need a triage process for, right? Tell the doc what's wrong.
Right.
So much of it is built around a billing system, right? When you go to the doc and even for your primary, your annual physical, and you're seeing that nurse first who's taking your blood pressure and your temperature, or you go into urgent care because you dropped something on your toe, right? And your toe's all purple, and they're going to need to, drill it and they're taking your blood pressure and they're taking your temperature. It's because the billing system is built around the number of diagnostics that they do, right? They got we've built all of this friction. So wait times, triage processes, measuring and testing things that don't need to be measured and tested. And so at Amaze, we said we're going to get rid of all of that friction. So we call it zero friction. One tap of a button, connected immediately to a medical provider. Relentless communication, so all unified communication. So you can send us an SMS. You can call us from a landline on our phone. You can send a message through a mobile app. You can go into a web browser. The easiest communication in the world. Constant communication, constant follow-up. So relationships evolve very fast. People don't let things fester. We put you on an antibiotic on a Tuesday and we call you on a Thursday. You should be feeling some relief by now. And you say, "Actually, I was feeling a lot better yesterday and I stopped taking it because it was really upsetting my stomach." That is the number one thing that causes antibiotic resistance, right? Is people not finishing their antibiotics.
Really?
Because people think antibiotic resistance is related to taking antibiotics and the bugs build up a resistance to it. And that's not actually it. It's when you don't finish your course of antibiotics and you haven't necessarily killed everything, the strongest of those bacteria survive and can leap out. So the most important thing is, even if it turned out you didn't need to be on antibiotics, you can never be sure. Once you start, you finish.
You finish,
right?
Okay.
And people think it's a good idea. Saying, "Oh, I'm feeling better. I'm going to save them for next time." And so now they've only taken the antibiotics for 3 or 4 days. Well, the only remaining bacteria in them is a few of the strongest, and that's what then escapes. So it's not that you as an individual are building up an antibiotic resistance. So when we follow up with people, it's an opportunity for them to say, "Oh, it was really upsetting my stomach," and explain to people that, some antibiotics will do that. We're killing all the bacteria in your stomach. Let's get you back on them. Let's get you on another antibiotic. Or maybe somebody's, strep throat, viral strep throat is starting to turn into an upper respiratory infection or a sinus infection. So it actually leads to better medical care when you have this continuity, when people can call and with any question they might have anytime and get quick answers. So it's a just-in-time kind of system that we start with. Now, when somebody's under our care, sure, we schedule appointments with them and that type of thing. So it's medicine as you know it. But again, zero friction.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Yeah. Well, and this idea is, if any interaction is necessary or believed to be necessary, you call a maze first, right? The maze is supposed to be that entry point, if you will, when it's a part of the equation, whether it's mental illness, whether it's something physical ailment, whether it's urgent or not. And of course, there's obviously, I'm sure, emergency situations where the right call is to 911 if it's that dire. But the majority, if not most, should come through a maze first, because then you can navigate through the system. So that's the idea, right?
So maybe, I think eventually we're even a better 911 system.
Really? Okay.
But I'll give you an example, true story. So we'd gone into a new client in the fall, publicly traded company, nice sized company. And about a week after the company's open enrollment is never the best time to roll out a maze. There's so much noise with everything else that goes on during open enrollment for employers, but employees had been introduced to a maze during open enrollment.
Okay.
Guy's at home one evening. His wife is just having the worst migraine of her life. She's had migraines her whole life. This one was just worse. And he says, call a maze. She said, what are they going to do for me? They're just a telemedicine company. And this was really important. He said, I don't know. They just said at work that we can call a maze for anything. So one of the reasons a maze does so many things is not that we want to own the world by doing everything. It's so that we can teach people that very simple message. Call us for anything. So he just said, I don't know. They just said at work, we can literally call a maze for anything. And so finally he shoves his phone in front of her. She hadn't installed the Amaze app on her phone yet. He shoves the phone in front of her, says, just tap the button, just call him, please. So she calls. Within 10 seconds, she's connected to a nurse practitioner. Nurse practitioner recognized pretty quickly that this was not a migraine. You know, we had that woman in surgery within an hour.
Wow.
Right? She was having a brain hemorrhage.
Wow.
But now, connect all of the things that had to happen, though, for this to happen. Mm-hmm. First, he had to be taught you call a maze for everything, right? Not here's a 2-page bullet point list of the services a maze provides. The second is it really had to be zero friction. Think about, she wasn't going to go onto Teladoc, and this is not an exaggeration. It takes 15 screens of answering questions on Teladoc's website to get to a doctor or to get to a virtual waiting room before you get to a doctor. You're having what you think is the worst migraine of your life. The last thing you want to be doing is looking at a bright screen full of little print going through screens, right? So he had enough trouble getting her to do it in the first place. If it wasn't that zero friction, she wouldn't have done it. So it had to be easy. He had to just know, I don't know if Amaze can help you, but they said to call Amaze for everything. We lead with our medical team, right? So there wasn't a triage process where she might have gotten frustrated, might have taken too much time. The triage, whoever's doing the triage might have, it's a migraine and not, right? So by putting our medical team out front, we just find things are much more efficient, right? So she was connected directly to a nurse practitioner. So everything had to go right there.
Yeah.
Well,
I can imagine if that intervention hadn't happened, she might have talked herself into, oh, it's just a bad migraine. Let me sleep it off, right?
Right. We heard from the CEO. So we'd only been in this company for a week. We hear from the CEO, oh, I hear you saved the lives of one of my employees' wives last week.
Yep.
You know, we save lives every day at Amaze, and that's not a cliche. I mean, the number of suicides that we know we've prevented, we've had people curled up in a ball on the floor in a dark, their dark bedroom, the windows closed, right, with a bottle of pills in their hands, and they've already made their decision. They're going to swallow it. But it was so easy to call Amaze, and they talking to a therapist or just a doctor, and they're all trained in the basics of mental health, within seconds, you've saved lives when those things happen.
If you don't mind, there was a story you were sharing with me earlier in the studio here about the gentleman that interacted with Amaze on that same line, and there's a very clear path for you guys probably preventing a suicide. Could you share that with us?
Yeah, I mean, true story. 9:12 in the morning, and the time is kind of seared in my head.
Well, yeah, you said it specifically
because
earlier,
it was kind of a traumatic event for the whole team.
Yeah.
But 9:12 in the morning, we get a message through our app, planning to kill myself today.
Okay.
So, at Amaze, everybody's part of one team, right? It's not that we've contracted with doctors all over the country and we'll transfer your call to some doc who's sitting at home taking some calls to make some extra money or while they're winding down their career. So that message immediately pops up on a screen. It's kind of like a Kanban board in manufacturing. Pops up on a screen, so everybody that's on duty and working together right now sees that message.
Okay.
So one writes to the rest of the team, do you think he's just screwing around with us because he's in the onboarding session? So we had somebody up in Fort Collins, Colorado, doing a new rollout of Amaze. Mm-hmm. So we have one of our account managers there standing up in the cafeteria with 80 people in the room. And we have everybody install the Amaze app. And we ask everybody to break the ice. Send us a message. Just introduce yourself, right? Somebody write, hi, I'm Spencer. I'm married. I've got 2 kids. My wife is going to think this is great. And we respond to them. So when we know we're doing those onboarding sessions, we get everybody on our platform, our lawyer, our HR managers, because we're just, because we could have all at once 50 people sending us friendly messages. And so somebody writes to the rest of the team, do you think he's just screwing around with us? And another one writes back, well, I don't think we can take that chance. So the team goes into action. So one person's trying to get a hold of the account manager that's doing the education session. Kind of knew she wasn't going to answer her phone. She's standing up in front of 80 people.
Yeah.
Somebody else is messaging the HR manager.
Okay.
Right? Somebody else is looking up, you can't really always trust the 911 systems when you're calling from outside the area. So they're looking up local EMS so we can make that direct call, right, to local EMS. But the HR manager looks down at her phone, sees the message, tells her there's been an emergency at the office. Would you please ask our account manager to take a 5-minute break and give the office a call? We didn't tell her what was going on. They'll just think it's one of her kids is sick at school or something like that. So this account manager of ours happens to be a physician assistant. She's able to confirm this guy is in the room. So now we know we don't have to dispatch the police, EMS,
right,
or whatever. So she's able to keep an eye on him. At the end of the session, she walks over to him and says, hey, Mike, hey, that message that you sent, was that real? And he said, oh, I didn't know anybody was really going to get that, but yes. And she said, okay, if it's okay with you, I'm on with my office right now. Can I have one of my therapists give you a call? Would you talk to him? And he said, okay. So she watches the therapist call him, right? And he steps out of the room. And the therapist does a deep dive. So this is a really important part of our mental health practice. Again, it's the zero friction, just in time. Right? When somebody's decided, so when people are calling us, in this case, we're calling him, but when people are calling us and they've decided it's time to find mental health support, think about what we put people through. And I'll go back to that in a second. But so this guy does a deep dive with the therapist. Therapist learns that he'd been on antidepressants for about 10 years. He stopped taking them 2 years ago. So not 2 days ago or 2 weeks ago, but 2 years ago when his company switched to a high deductible plan. So it'd probably been almost exactly 2 years because we're in open enrollment here, right? So it was costing him $240 every 3 months to go to a psychiatrist to get a refill prescription on his meds. So he stopped going. Psychiatrist's office doesn't call and check in on him, all right? It's out of sight, out of mind. You cancel your appointment, that's your business. So he stopped taking the antidepressants about 2 years ago. So he's probably been in some kind of, spiral ever since. So the therapist, as he's doing this deep dive with him, gets on another screen and says to one of our nurse practitioners who's got her doctorate degree in psychiatry, taught at a university in this psychiatric program for nurse practitioners, says, hey, I need to get this guy back on his meds. Can you join my call? So the nurse practitioner joins the call. They review some of the history. She gets the medication history. To make a long story short, by noon, we've got him back on his antidepressants. 3 o'clock in the afternoon, he gets back on the phone with the therapist. This guy had checked every box. He had a gun, it was loaded, sitting on the front seat of his car. He had decided when he was going to kill himself, where, why. He had already gone through the thought process. Am I going to leave a note? Who's it addressed to? So the therapist talks him into unloading his gun, taking it to a neighbor, giving the neighbor the gun and our phone number, and asking the neighbor to call us so we can tell him why he's locking up the gun and why he's not giving it back. He has 2 more sessions with that therapist. We then step him down to what we call our peer support team. For about a week, every day, he's messaging back and forth with the peer support partner. I had about a 20-minute call on the phone with him so they can meet. So they're building some rapport and relationship. So this is where this guy is now. He's got a crisis management system. Anytime he needs, he can open up a mobile app and touch a button. He's connected to a medical provider, right away. He's under the care of that nurse practitioner. Every month, he completes a depression screening, and his peer support partner checks in with him. Now, to get his refills, he needed to be on the meds. The psychiatrist had it right.
But if you do the math, right, at $240
Cost him $1,000
a year. Yeah,
right.
yeah,
And time out of his day, hourly worker, right, taking time off, right?
That's the friction you're talking about.
Right, that's the friction, it's the cost. So now his cost is zero, right? His company just pays for his subscription to Amaze. He's got his crisis support team. The peer support partner checks in with him. All he has to do every month is he needs to respond to the peer support partner. Hey, thanks for checking in on me, doing great. Because that way he's reminded, he can also say, this particular gentleman did once, hey, I thought I was doing great. My mom died 3 weeks ago and I'm not doing so good. And that peer support partner can either say, do you want me to schedule you with the therapist, or you want to just, you and I talk? Right? So he's got this support system, but our marginal cost to serve this patient is essentially zero.
Yeah.
Right? The message goes out every month from the peer support partner. He reads it, makes sure everything's good. Our technology tracks, is he doing his depression screening? We can track the scores, make sure he's not trending. And he knows he can escalate to the nurse practitioner, to the therapist, to a doctor in 15 seconds, anytime. And so our focus is on solving problems. The mental health system in the US, and it's kind of like the medical system. Look, I think doctors want to do the right things. The system doesn't allow them to. Same thing in mental health. Mental health is a recurring revenue model. It's all about scheduling the next appointment for the psychiatrist, for the therapist. With Amaze, our goal is to keep our price point low enough that the gentleman I just described, he'll be an Amaze customer for life, right? And that's also very important about Amaze, the portability. So if he leaves his company, if he loses his job, Amaze is affordable. Amaze will be his partner for the rest of his life.
So an individual can decide to then pick up. Okay.
We don't broadly advertise it. We're getting ready to. But when somebody leaves a company, yes, they just convert into one of our consumer customers. They go to another employer that's an Amaze customer. They have what's called a lifetime account number. They just attach that account number to the employer's account, and it goes on the employer's account.
That's fantastic.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
Can I ask you something? What happens, though, David, in an event that a physical surgery or interaction is required at some point? So I triage with you, or I go into Amaze, not to use the word triage. You go, Spencer, I really think that knee needs to be looked at, or I think you need an X-ray, an MRI, and then maybe surgery follows suit. What role do you play in that?
So we become your navigator, your case manager, your guide, your partner. So we do, in many respects, the same thing as the firms you might define as patient navigation services. Mm-hmm. We just don't think that can be done well if it's not being done by the medical partner. So, for example, you're out playing tennis on a Sunday afternoon and you twist your knee and you go down hard and you hobble your way over to the car, and your buddy says, you want me to drive you to the ER? And you say, well, hang on a minute. Let me just check with Amaze first. Right? When you first react, right, you're not bleeding to death.
Right.
Right? You think you tore your ACL, but you're not bleeding to death. So let me call Amaze first. You can do it on the way, right? You can say, oh yeah, let's start heading over there. And when you call Amaze, we've got orthopedic specialists, right? And somebody would say to you, yeah, you can go to the ER. I don't really think you need to be in the ER. Why don't I just put in an order for an MRI and get an MRI done tomorrow morning, right? So we can put in the order for the MRI. We're contracted with the major carriers. We put that in as an network order. Especially if we're working with an unbundled plan where the employer has a lot more sway with their TPA and says, hey, look, if the order is coming from Amaze, I want that to be pre-authorized, right? Amaze is not referring to itself. Amaze doesn't make any money on that. So we have total trust in Amaze. That's very important. So there's some key principles to Amaze that are super important. The trust, the independence, the fact that the patient navigation and medical team are one team. But now we get the MRI back, and it is a torn ACL. Our app, we can't repair ACLs yet. We just don't have the technology to do it. So we got to get you to an orthopedist. So what have we accomplished? First of all, we cut out the first unnecessary $220 visit to the orthopedist. We all know what that visit was going to consist of. It was going to be an MRI ordered, right? So we got the MRI ordered. So that cost is gone. You're getting that MRI on Monday or Tuesday instead of waiting 3, 4, 5 days, 10 days to see the orthopedist, only to have an MRI order first put in. When the orthopedist puts in the order for the MRI, you really are not influencing where that order is going to. If you had a specific request, they would honor that request, but you don't know enough to have a specific request, right? So at Amaze, the words we use is direct, don't redirect. So when you go to the orthopedist, they put in an order, and the imaging center calls you up and says, sir, we did an eligibility check. We see you have a $6,000 deductible. The MRI is going to be $1,500. We'd like to get your credit card now to schedule that. And then you go into the panic, and you go running to your HR manager, and they say, oh, we've got this patient navigation service. You should call them. They'll help you get it to an independent imaging center. You can get it done for $600 or $700. But to do that, first you got to get on the phone with that company. They'll find you an imaging center. Then somebody's got to call your doctor's office and have the order sent in again. Data suggests that people only actually allow themselves to be redirected about 15 to 20% of the time.
Okay.
Right? Suppose you work in a factory and you got Mickey Mouse ears on all day. And when do you make these phone calls in the first place, right? It's not easy. The order's got to be moved. Then you got to get through the pre-authorization process. So now you're potentially talking about weeks, right? So very often people will just say, I'm just going to have the $1,500 MRI, just get it done. So when the order is moved, we call that redirecting, right? Redirecting you to lower cost care, that kind of thing. At Amaze, by making ourselves that first touch point, we get to direct you without ever having to redirect you. So we cut out cost on the front end, but we go further. Let's say it's not an orthopedist. Let's say we're sending you to a cardiologist. We might call that cardiologist and say, look, based on the symptoms and the reason I'm sending my patient to you, we're 99.9% sure you're going to want to put that patient in a Holter monitor, right? Monitor your heart rate, 24/7. Do you want, doctors have different preferences. Do you generally order 14 days or 30 days in that Holter monitor? Doctors say, oh, why are you asking? So, well, we're going to go ahead and order that before they get to you. When we first started doing this, we thought doctors would say, oh, well, no, I need to see them first, and I'm not getting paid for that first visit. They never do. They always say, that would be great.
Okay.
Thank you. It's so great to have somebody to work with. Good specialists today are so busy, they'd rather be seeing more patients who really need them, right? So it's actually a really good partnership.
Well, and one of the core inefficiencies in that handoff that you're describing is, and you see other entities pop up to help redirect, if you will, to care or offer or proffer different options. So the MRI is a great example. You get referred here, find out that MRI is $4,500 and their share is $1,500, or you go here that's a mile down the road and it's a freestanding MRI center and it's $700. Most patients, if given the two choices, would go to the less expensive one because an MRI, relatively speaking, is the same thing, and then it needs to be interpreted by a doctor. But I don't care if I get the $4,000 MRI or the $700.
Right.
I know for me, it's less expensive over there, so I'm going there. There's an inefficiency in that handoff that often
100%.
happens. So you guys are participating and even directing that handoff.
That's right.
But how much information are you getting about the pricing methodology or the quality metrics that are included in that decision?
Sure. So So we use a lot of different data sources. Data that comes from the clearinghouses will tell you what doctors are billing which insurance carriers for what procedures and how often. The how often is often the first kind of proxy for quality. The pricing information, that we didn't get into it, but if you remember, I had a big hand in writing the transparency and coverage rules. So we've known how to use that data from day one. So we can look up what's been negotiated for every coded procedure, for every medical provider, for every insurance company in the country, right? So we have all of that pricing information. We call, so we act as a concierge to whatever extent somebody wants. So, right? Me personally, I don't want somebody scheduling things for me. I have a busy calendar. I need to be looking at my calendar. I want to make those decisions myself. But if you said to Amaze, oh, I'm free anytime next week other than Wednesday, we'll go ahead and schedule the appointment for you. So we've got the pricing information, right? We've got your plan. We're connected to your carrier via API. So we've got the plan on all the information on your individual plan, right? So all of that information is easily accessible these days.
Okay, right on. And then so if we can focus before we kind of zoom out, David, the employer experience, right? Because a lot of what you're talking about, it dovetails with the audience that I have, which is brokers listening or employers that are self-funded and want to deploy solutions like this across their population. So talk to me some of the basic blocking and tackling of how would I roll an Amaze out? Who is the right profile of an employer? What exactly are you solving for in the spectrum? Let's kind of focus on that lens for a second, if you don't mind.
Sure. So in the business you're in, I'm sure you've heard the phrase point solution fatigue.
Sure. Oh,
right?
Yeah. I say it a lot.
Right. So,
Yeah.
so there's a lot of very narrow so-called point solutions out there. And quite honestly, they were all created with good intentions. A lot of them are capable of doing very good work. For the employer, managing 5, 6, 7, 8 different vendors, we hate the word vendor,
Solution providers, whatever
right?
you want to call them. Yeah,
But managing 5, they're all vying for your attention.
Yep.
They've all got their own sales process, and they all want to prove their worth by engaging with your employees. So employees are getting 4, 5, 6, 7 different communications from all these different companies. Most of them don't need any of them, right? Not everybody has a musculoskeletal or orthopedic issue every year. They're not all smokers looking to quit smoking. Contrary to popular belief, not all Americans are fat and need to lose weight, right? And so they've got all of these different solutions. A second opinion service. And so the employees never really get to learn any of them because they don't need them, right? So when Amaze goes into a company, the theme that ties everything together that we do is one partner, one platform, one name to trust. So when an employer says to us, well, we've got these other services, you say, well, then it's not time for Amaze.
Because you're displacing quite a
right.
bit.
It doesn't make sense.
Yeah.
Client says, well, we've got a diabetes management system. Well, then it doesn't make sense to invest in Amaze. You're just going to confuse your employees. So Amaze generally replaces everything except the underlying insurance. We were talking a few minutes ago about needing that MRI, right? We can't do MRIs and we don't pay for MRIs. So we're not the insurance. We're not a replacement for your insurance. You still need payment solutions, payer solutions. But we do everything else, right? So we are the virtual urgent care, the virtual primary care, the mental health, the patient navigation and care coordination, the second opinion coordinator. We literally say at Amaze that there is no such thing as a health or medical problem for which we are not your partner. We have CEOs, they give up their $5,000 or $10,000 a year concierge doctors for Amaze. Somebody was telling me a story just a couple of weeks ago about a 26-year-old employee saying to the CEO of a company, you have a concierge doctor, don't you? And he said, yes, I do. She said to him, my concierge doctor is better than yours, right? Because she has access to Amaze. And we are, because we have a full breadth of capabilities, 24/7, the patient navigation and care coordination services, right? So there's nothing a concierge doctor can do for you that Amaze doesn't do and probably do better. So for the employer, the the first priority is always, all right, how do we bend the cost curve and drive down cost? We do that in some unique ways, in addition to the navigation to lower cost services and managing the chronic medical conditions. We also do things like reducing specialist visits by about a third. I gave you the example of a Maze ordering an MRI or Maze ordering a heart rate monitor before you go to the cardiologist. We often eliminate visits to a specialist on the front end and on the tail end. Once that cardiologist figures out what's going on with you, figures out you need to be on a different medication, you weren't responding to certain medications, maybe because of a genetic issue or whatever. Once you're on the right medication, their routine is to say, come back in 6 weeks so we can, check your blood pressure. Right? And our patients will call us and say, do I really need to go back? And we'll say, no. We can check your blood pressure. We'll just, drop your doctor a message and let them know we did.
There's two things I'm hearing from you, and then I think we'll zoom out because just in the interest of time and getting to the big picture of healthcare. The friction component, you eliminate a large amount of friction, but kind of in the same vein, the inefficiencies in the system of all the back and forth and the checkups and the follow-ups, et cetera. Those are often done by different entities at different points of that healthcare spectrum. They can just centralize a lot of that with you.
Yeah, so that's a great lead in. So I was saying the first thing employers are always looking for is how do we drive down cost? But within a few months, all the feedback we get from them isn't just about cost. It is about the experience of their employees, right? Their employees, if you go online and read what people write about a Maze online, it even boggles my mind. I mean, people get very personal. They talk about their mental health challenges. Mm-hmm. They put their name on their reviews. They call out my medical providers by name. It's a relationship that evolves and that stands the test of time very quickly. So for employers, I've had a lot of chief HR officers say to me, David, I've been in HR for 30 years. I don't think I've ever once had an employee stop by my office to say thank you. Now they do it 3 times a week. Thank you for a Maze. One of them told me she keeps a yellow pad now on her desk so she can write them down. Publicly traded company, lots of employees. She's like, I want to write these down so that you guys can come in and interview them all and do some videos and that type of thing.
Yeah, because you get the water cooler effect.
But this is customers doing this for us. The CEOs of our clients will take calls from other CEOs. I don't know CEOs taking calls about ancillary medical services, right? But usually they can't even name them. They've got their concierge doctors, right? With a Maze, it's interesting. The thing that often makes the impression on the senior executives, they tend to be on the older side of things. So a lot of them have college kids. College kids are the worst hypochondriacs, right? They're away from home, first time, they get sick, hungover, dehydrated, whatever it is, mom's not there. So we take a lot of care of a lot of college kids. We're now getting to the point, we're still only a few years old, but we're now getting kids going off to college who have been under our care for 3, 4, or 5 years, as they were teenagers. We might be treating their anxiety, writing the prescription for their birth control pills. Who knows? Whatever it is, they go off to college. They already have a relationship with a Maze because they've been calling us with their parents for the last several years.
Yeah.
So ultimately, that's what we want a Maze to be about. It's the quality of care. We're constantly developing new and better models of medicine and mental health, but it's the quality of care. Yes, cost is important. We do everything that anybody else does to manage cost, and I think we get to do a lot of it better, right? Direct, don't redirect. The medical team is the patient navigation team. It makes all of that cost management easier to effectuate. But ultimately, it's about the experience and the quality of care and the relationships.
Yeah, and so let's zoom up on the experience then. Inside and outside of Amaze's impact, you've obviously helped write policy as well. Like, what do you see the next couple of years of healthcare actually look like in the United States? Are there any big changes that you foresee happening, in the short amount of time, or what?
Yeah, so there's a lot of trends that are converging. Obviously, there's a lot going on in Washington. We might see more people without government-sponsored healthcare. We also see more and more employers, especially those employers at the margin, the medium-sized, small, medium-sized companies, opting out of providing any insurance to their employees. The employer mandate has sort of become a joke, so companies aren't feeling, as long as they offer an affordable, compliant plan, whether their employees opt into it or not, doesn't matter. They're not subject to the penalties. So more and more companies are opting out of providing their employees with insurance at all. The quality of that insurance is getting weaker. It seems that the big carriers are making so much money on Medicare Advantage plans that they are, not worrying as much about the private marketplace. There was some restraint on inflation for a few years. The government put a lot of pressure on health systems to not be jacking up their prices much because of all the government stimulus they'd gotten. I mean, the COVID stimulus lasted a long time in healthcare. And so now all of this inflation in society is making its way into salaries in healthcare, right? Nurse salaries going up a lot, and so on. So there's a lot of upward pressures on cost, fewer people with good coverage. I think the biggest trend that we're going to see ourselves driving is a return to really good primary care.
Okay.
I think the Affordable Care Act was well-intentioned. There's a lot of big critics out there. And I'm a critic, but I'm a critic through the lens of economics, not politics. It just doesn't work to try to engineer what is now the third largest economy on the planet. It doesn't work.
You said that earlier, to be specific, healthcare in the United States is the third. So you've got USA's global economy, you've got China, and then you've got our healthcare system.
Yeah, when I started talking about healthcare and research that, the U.S. healthcare system ranked as the fifth largest economy. So you had the U.S., China, Japan, the U.K., and then the U.S. healthcare system and Germany were about tied for fifth.
Okay.
Today, the U.S. healthcare system would rank as the third largest economy on the planet by itself. So anybody that thinks they understand the American healthcare system, that would be like saying, I understand everything about Japan's economy. Right? You can't. It's that complicated a system. But one of the unintended consequences of the ACA was trying to make more primary care available to Americans. We watered it down to next to nothing, right? You can, now a primary care visit is basically lab work and talking to your doctor, right? They don't need to put a stethoscope on you. They don't need to have you strip down and do a dermatological exam. Instead, they tell you to go see a dermatologist once a year. So instead of driving the cost of primary care down, we've actually driven it up. Right? I live in Colorado, you live in Texas, right? The sun is strong. You get to my age, doctor's going to say, go see a dermatologist every year. That's just added another $150 to $180.
And another appointment, more time out of your day.
Exactly. So primary care has been severely weakened in many ways. Doctors are doing less. People are getting, they'll come in and talk about their back pain and they're going to get a bill. Right? Because that's something diagnostic, not covered by the annual wellness exam. We've had doctors tell some of our patients, sorry, I can only diagnose up to 2 things in this visit, and then you have to schedule another appointment. So we've really broken, in an effort to make primary care available to everybody, we've really broken the primary care system. So that means less preventative care is actually happening, less is getting uncovered or unearthed during those primary care visits. And at the same time, technology is really improving fast. Blood pressure cuffs, everybody should just have a set at home. They cost $25 on Amazon. I remember when my first kid was born, we'd race out to buy a digital thermometer so we didn't have to stick a glass bulb up their butts, right? And we'd pay $100, $120 for that, back in the mid-90s. Right? People can spend $25 or $30 and get a good set of digital blood pressure cuffs at home. There are now digital stethoscopes that will live stream that we can put in an office on an employer's site. Super high, cardiologist grade live streaming stethoscopes. With a KardioMobile, we can get a 6-lead EKG, picks up things like AFib. Your local doctor's not doing that when you go in for your annual physical. They're not even putting a stethoscope on you in most cases. So technology is allowing us to do all kinds of things virtually, and the technology just keeps getting better and better. And so coming out of Amaze, creating that primary care relationship makes everything else happen that much faster, right? You're more likely to call us when you get sick. You're not likely to let a medical problem fester. I use the example of dermatology. People let skin cancers fester for a long time. First, should I have somebody look at this? Who should look at it? Do I need a referral from my doctor? I got to go see my dermatologist wants to give me an appointment 4 months from now. I'm not really going to go to urgent care. They're just going to tell me to go. People die because of this, right? And with Amaze, they snap a picture of it and say, hey, can you take a look at this for me? We get on a call with them. You can actually do at-home very effective biopsies these days. Send you a test kit. It's a super strong adhesive. When you rip it off and send it into the lab for testing, they're actually testing the DNA. So they know that they got a good sample because they're actually testing the DNA in that skin, right? So that kind of technology's coming very fast.
I've sensed a movement of the last couple of years of where my interest lies, but also that I think the interest in the marketplace lies. It is a reimagining, a reinventing of the primary care models. And there's different forms of that, the DPCs of the world, whether it's brick and mortar or virtual, what your guys are doing. But I'm just saying, it seems like there's a genuine understanding that we broke primary care, and we're trying to
think about the other
that.
part of it. So you got hospital systems buying up primary care practices, right? Yep. Primary care providers are paid at the lowest end of the scale, even paying for an electronic medical record system. If they can get that for free from the local hospital system, that makes a difference. So you're getting primary care practices bought up by the local hospital systems. Hospitals don't want to be in the primary care business. Why would they want to be in such a low margin business? It's for the referrals to their specialists. Over the last decade, the ratio of primary care visits to specialists is inverted. 10 years ago, it was 2/3 primary care, 1/3 specialists. Today, it's 1/3 primary care, 2/3 specialist. I gave you the example of me going to my own doctor, and she says to me, go see a dermatologist once a year, right? You complain of some mild stomach issues. Your doctor used to talk to you about your diet. Maybe it's early signs of an ulcer, your stress. Maybe they'll put you on an acid reducer. Now it's, let me refer you to the gastroenterologist in our group practice. So primary care got broken by the ACA. It's getting further broken by the acquisition of primary care practices who really just want the primary care business for the referrals to the specialists. The specialists want the business for referrals into their procedures, right? Because that's where all the money is.
Yeah.
And so we've broken primary care on many levels. That self-referring model is corrupt is probably too strong a word, but it's not a good model. Amaze brings total independence, right? So the trust and the independence that comes with this virtual model that's not plugged into the local health system, that's a real game changer. And so it allows us to do much more of the patient navigation and care coordination. It allows us to make good, high quality referrals. It allows us to keep people. Our first goal is always just, let's keep you out of the system in the first place.
But out of the system, and I'll ask you for your closing thoughts next. Out of the system, but not preventing you from getting to the system when you need it. But not out inside the system unnecessarily because you don't know what to do and you're stumbling around in the dark, right? You've got a care navigator or a guide, an advocate with you, helping prevent you going in the system unnecessarily. Ooh, my wife's calling. So in the interest of time, David, not because my wife's calling, but because we got to get out of the studio. The last thing I usually ask for the folks is closing thoughts, right? So we've talked probably an hour and a half, right, Nathaniel? It's been... there you go. So hour and 20 minutes. We've covered a lot of ground. Folks that have made it this far and said, well, I'm really interested in that. What is one or two things you want to leave them thinking about as they go about their day?
So the healthcare system is going to get a lot worse before it gets better. Okay. It's just such a complex behemoth with so many special interests, so much law and policy intertwined in it. At Amaze, we're trying to bring a really simple solution to a really complicated problem. Give every American a trusted, independent health and medical partner who's there for everything they need for the rest of their life. So total portability, full range of capabilities, and we just fiercely defend that independence. And we think by doing that, we can really change the dynamic of how patients interact with the system. Everything else is dominated by the payer and provider model. We're just looking to provide the patient model and to keep things that simple.
I love that. Awesome. Well, great way to close off, David. Again, I appreciate you coming down. I'm really excited to sit down and talk to you, but also to release this one to the world here in a couple of months, man. So thank you again. And I look forward in a couple of years, maybe catching up and doing round two with you.
Yeah. Thank you for having me.
Appreciate it.
Really enjoyed it.